Bismillah ar-Rahman ar-Rahim. My talk today will be about acid-base management in renal patients. And here is my agenda. First of all, I will talk about acid-base disorders in acute kidney injury. The major part of our talk will be about acid-base disorders in chronic kidney disease, the pathophysiology of metabolic acidosis and its adverse effects, and how to manage in chronic kidney disease patients. Also, we'll talk about acid-base disorders in hemodialysis patients, with a brief hint about acid-base disorders that might occur in peritoneal dialysis and in renal transplant recipients. And we'll end the talk by some questions to emphasize important points. First of all, the acid-base disorders in acute kidney injury. In acute kidney injury, the usual daily excretion is impaired. Therefore, metabolic acidosis develops, and usually its type is high anion gap. This is the most common acid-base disorder that occurs in patients with acute kidney injury. There are other types we will discuss in the next slide. We have to treat the etiology of both metabolic and, if associated, respiratory acid-base disorder. It will be an important aspect in the management of AKI. Also, to give sodium bicarb and renal replacement therapy at its time, improve not only acidosis but renal functions as well. This table shows the different types of acid-base disorders that might occur in patients with AKI. As we said, the most common type is the high anion gap metabolic acidosis, which occurs due to accumulation of endogenous acids as sulfates and phosphates. In critically ill patients, we might face conditions of very high anion gap metabolic acidosis. That's a high anion gap of 30 or even 40. This is usually associated with lactic acidosis due to sepsis or hypoxia. Some rare cases of high anion gap mixed with non-anion gap metabolic acidosis occurs due to additional cause as diarrhea or renal tubular acidosis. In AKI patients following intubation, we might see a case of both high anion gap metabolic acidosis and metabolic alkalosis as well due to vomiting and nasogastric suction. Also, high anion gap that might be associated with respiratory alkalosis in patients with pneumonia or sepsis, and that's rather common. And rarely we might find associated respiratory acidosis in case of COPD or CO2 retention. What about the acid-base disorders that happen in chronic kidney disease? We have to go back to some physiology. The typical Western diet generates net non-volatile acids around 1 milliequivalent per kg per day. That's around 60 to 80 milliequivalent daily. These acids are relying on the kidneys to excrete. In healthy individuals, metabolic acidosis does not occur because the kidneys excrete this acid load and maintain the bicarb around 24. The maintenance of bicarb is achieved by three renal mechanisms. First of all, reabsorption of all the filtered bicarb. Secondly, generation of new bicarb by titrable acid, which is mainly depending on phosphate. Number three, formation of bicarb from generation of ammonium. All the bicarb is freely filtered in the glomerulus, around 4,000 milliequivalent per day. But almost all of these amounts are reabsorbed by the tubular segments, mainly by the proximal tubule, leaving the urinary excretion of bicarb very negligible amount. But additional bicarb has to be generated, as whenever a hydrogen ion is excreted into the tubule, it combines with the filtered bicarb, or with two important urinary buffers, namely LHPO4 with ammonia to form H2PO4 and ammonium respectively. So for each hydrogen ion that combine with HPO4, a new bicarb is formed and reabsorbed. The process is slightly different with the ammonia. When the ammonia is converted to ammonium, in this conversional bicarb is formed through the glutamine metabolism. So to sum up, about hydrogen ions, 40% is excreted through phosphate, which is known as the titrable acidity, and the remaining 60% as ammonium. Now, what is the net acid excretion? Net acid excretion is defined as the sum of titrable acid plus ammonium minus any filtered bicarb in urine. What happens in CKD? In CKD, functioning mass decreases. However, the remaining referents start to get hypertrophied to increase the GFR. So the rate of titrable acid excretion, which, as we said, depending on phosphate, is usually normal or slightly increased even. However, the problem is in the excretion of ammonium. Excretion of ammonium is decreased and hydrogen is retained with development of metabolic acidosis. So we conclude that the ammonium is a major urinary buffer in both normal and CKD patients. This is the pattern of acid-base disorders in CKD. Usually starts in early stages by non-anion gap metabolic acidosis due to bicarbonate wasting. Later on, there is mixed non-anion gap and high anion gap metabolic acidosis, and in stages 4 to 5, usually we have high anion gap metabolic acidosis in most of the patients. So to sum up, what are the mechanisms of metabolic acidosis in CKD? The major mechanism is decreased ammonium excretion and production by the failing kidney, especially when the GFR is less than 15 milliliters per minute. Also, decreased senses of ammonium by hyperkalemia, decreased conservation of bicarb by the failing kidney, insufficient titrable acid, phosphate compared to the acid load, increased production of anions such as sulfates and phosphates due to high protein intake, increased catabolism in some malnourished patients generating sulfates and phosphates. Of course, metabolic acidosis have deleterious effects on the whole body systems, including hypoalbuminemia, progression of kidney disease due to induction of fibrosis, bone disease. As we know, the bone acts as a buffer for the acids, insulin resistance. In many patients with renal patients have glucose intolerance due to metabolic acidosis. It decreases the level of growth hormone and IGF-1, increase the pro-inflammatory cytokines and inflammation, suppress the cardiac contractility, and also leads to muscle wasting. So how to treat? The KDIGO guidelines 2013 make the following statement. We suggest that in people with bicarb concentration less than 22 millimole per liter, treatment with oral bicarbonate supplementation be given to maintain serum bicarb within the normal range unless contraindicated. So we have to normalize the serum bicarb. We have two important ways to increase serum bicarb, either to use sodium bicarb or sodium citrate sometimes, or to reduce the dietary acid load. These are the different alkali preparations available. We usually use sodium bicarb or sodium citrate. We avoid the potassium-containing alkali preparation due to risk of hyperkalemia. Sodium bicarb recommended dose is from half to 1 milliequivalent per kg per day. However, usually we do not use this very high dose. Each 650 milligram tablet of sodium bicarb contains 8 milliequivalent bicarbonate. What's more available in Egypt is the 500 milligram tablet or capsule. It contains around 6 milliequivalent bicarb. But according to many experts' opinion, we should not increase the dose above 6 grams per day, and usually we use from 2 to 3 grams per day. Sodium citrate is an alternative to sodium bicarb. It's more expensive. It has a side effect that it might increase aluminium absorption from the GIT, and of course, never to use if we are going to use aluminium phosphate binders. Also, if the patient have liver damage, do not use it because it relies on the liver to convert citrate to bicarb. Should alkali therapy be reserved for patients with metabolic acidosis only? According to some papers, no. We can give sodium bicarb even to patients with normal bicarb. Why? They found that this can preserve the GFR of the patient as it decreases the compensatory responses that facilitate kidney acid excretion. Because these compensatory responses on the long run will cause kidney damage. So we have to stop it early by giving bicarb to prevent the metabolic acidosis in the first place. Number 2, to reduce the dietary acid load. From where the acid comes in the diet? From animal-derived protein. Okay, daily acid load should be decreased in renal patients with metabolic acidosis by recommending foods that generate low hydrogen production. And this we can calculate it from the net acid index. It is an indicator of the acid load in the food. Rammer and associates developed a model for this acid load, بسميها potential renal acid load, which is helpful in preparing the daily required food. And we can give this paper to the patient. Any foods that have a positive value means that it have acidic effect on the body. Any foods which have a negative value, that means that it have alkaline effect on the body. Of course, the fruits and vegetables, it have alkaline effect. Meat and meat products have positive. Cheese with, as we see, low protein content gives 8. Cheese with high protein content gives 23. So this is the different daily acid load of foods. So fruits and vegetables, we know that it have alkaline properties and they are better choices than the use of sodium bicarb alone in CKD. Mostly we do not use just fruits and vegetables. Usually combine this with sodium bicarb. They found that fruits and vegetables might improve metabolic acidosis, decrease the kidney injury markers, decrease systolic blood pressure and weight and urinary albumin excretion, but always take care of hyperkalemia. Veverimer or Trisida is a new agent that is suggested to decrease metabolic acidosis. It acts by a very different way. It selectively binds and eliminates hydrochloric acid from the gastrointestinal tract. And in preliminary studies, he found that it might improve the serum bicarb. It found it to be safe and decrease the progression to end-stage renal disease or death. However, still it's not FDA approved, and we still need more RCTs and more large-scale trials to use it. Let's move to acid-base disorders in hemodialysis patients. In a large cohort of ESRD patients, they found that half of these patients are not meeting the targets. Their pre-dialysis bicarb is less than 22, so they suffer from pre-dialysis acidosis. Also, during the hemodialysis treatment itself, when there is a large surge of bicarb entering the circulation, it overcorrects this acidosis into overshooting alkalosis. This large acid to base shifts have a deleterious effect on the mortality of these patients and multiple adverse outcomes. So we usually recommend that in dialysis patient, the pre-dialysis bicarb should be maintained more than 22, the midweek level around 27, because levels less than 18 and more than 27 are associated with high morbidity and mortality. What are the current dialysate solutions? Modern solutions use usually bicarb and its precursor acetate. Some dialysate contains citric acid in place of acetate. The concentration of bicarb usually ranges from 35 to 37, with the acetate ranging from 4 to 8. This picture shows the different acid to base shifts that happen during the hemodialysis. First of all, when the dialysate bicarb enters to the blood, there is sudden alkalosis. This sudden alkalosis affects the peripheral chemoreceptors, inhibiting the respiratory center. This leads to some sort of respiratory distress to the patient and hypoxemia. Also, sudden alkalosis may lead to hypocalcemia and hypokalemia and initiate cardiac arrhythmias. This happens in the first 15 minutes of dialysis. Later on, the formation of H2CO3 converted to CO2. CO2 will stimulate the peripheral chemoreceptors to stimulate the respiratory drive to get rid of this hypercapnia. But in many of our dialysis patients, we have ventilatory compromise. They have COPD, they have heart failure or fluid overload. So they cannot get rid of this excessive CO2. So as we see that these large acid to base shifts have multiple adverse outcomes on different body systems. So we have to deal with this. We have to put strategies to decrease the severity of dialysis-associated acid-base disorders. They suggest that to give alkali. Give alkali on non-dialysis days, because the pre-dialysis acidosis, they found it to be minimally affected by the dialysate bicarb. So give alkali on non-dialysis days, this sodium bicarb, to reduce the incidence of intradialytic hypotension, and they see that it is well tolerated in end-stage renal disease patients. The second strategy is to reduce the dialysate bicarb. If pre-dialysis acidosis can be reduced, so dialysate bicarb can be safely reduced to avoid this shooting alkalosis. Okay, and the best way they see that you can increase the bicarb at the beginning of the session, and during the session you can decrease the bicarb concentrate towards the end. Also, using acetate-free biofiltration is not something new. It's a method of hemodiafiltration that is based on buffer-free dialysate. We do not put any buffer in the dialysate, but we have a high flux membrane and sterile bicarb infusion in the post-dilution method. They found this method can improve systemic hemodynamics with better acid-base disturbance, especially in elderly patients. And always advise the patient to optimize his volume status. They found that large interdialytic weight gain is associated with pre-dialysis acidosis. Why? Because there is dilutional decline of serum bicarb. So always advise the patient to decrease his interdialytic weight gain. Let's move to acid-base disorders in peritoneal dialysis. As we know, the current PD solution contains lactate as a buffer, and that's used after discontinuation of acetate. A third solution consisting of lactate and bicarb was introduced, while another PD solution diuretic by Versenius can fiha only bicarb. During routine PD, lactate diffuses into the blood while bicarb enters the dialysate. This large acid to base shifts does not happen in PD. Why? Because the lactate is constantly converted into bicarb and improving the metabolic acidosis. This is achieved in both CAPD and automated PD. Metabolic alkalosis might infrequently reported, غالبا بيبقى associated with low protein intake in these patients. Lactic acidosis might occur if this patient have liver damage, because of course the lactate cannot be converted into bicarb. What about acid-base disorders in kidney transplant patient? It's not studied, not studied well, but in few studies showed that there is renal tubular acidosis is the most frequently encountered disorder in renal transplant recipients, with prevalence can ranging from 12 to 58%. In most of these studies, serum bicarb was less than 22. And they found, interestingly, that this metabolic acidosis develops at higher GFR levels compared to CKD patients. The first type, proximal RTA, usually occurs in 19% of the cases. Usually it's transient and occurring only in the first 3 months. of transplantation. They related it لأن هو موضوع فيه ischemic tubular necrosis. Ischemic tubular necrosis in the harvest procedure leads to proximal RTA. If it develops late, it might be due to chronic rejection. The distal RTA, it may develop as early as first 3 months and may last up to 9 years. وusually بتبقى related to chronic rejection and calcineurin inhibitors, especially tacrolimus, and you have to treat it by giving alkali. Type 4 RTA usually برضو might be seen in cases of cyclosporin and tacrolimus. Type. Some questions, يعني you are all invited to answer. Question number 1. Which one of the following mechanisms is involved in the development of metabolic acidosis in patients with CKD stages 4 and 5? Loss of bicarb from extrarenal source, ولا hyperkalemia, ولا decreased serum phosphate levels, ولا decreased ammonium excretion, ولا all of the above? Excellent. هي فعلا decreased ammonium excretion. هو ده the most important mechanism for metabolic acidosis in CKD. طيب. Question number 2. Which one of the following complications is expected to see in a patient with chronic metabolic acidosis? Muscle wasting or hypoalbuminemia, progression of kidney disease, development of bone disease, ولا all of the above? All of the above طبعا. طيب. كل دي طبعا complications of different metabolic acidosis. Question number 3. Which one of the following serum bicarb concentration in a CKD patient with metabolic acidosis warrants supplementation of oral bicarbonate? Less than 16 ولا less than 18 ولا less than 20 ولا less than 22 ولا less than 24? 22 صح. هو ده according to the KDIGO guidelines بندي البيكارب لو البيشنت bicarb less than 22. Question number 4 هي case 50-year-old non-diabetic man with estimated GFR of 24 milliliters per minute. السيروم bicarb بتاعه 20 despite huge oral sodium bicarb dose بيديله 12.5 grams per day. والurine pH 5.4 و his only complaint of bloating of his stomach. Which one of the following is the most likely explanation for his low serum bicarb despite you are giving so much dose or too much dose of bicarb? هل هو non-compliance للصوديوم bicarb ingestion ولا high protein intake اللي هو الميت ولا low consumption of fruits and vegetables ولا all of the above ولا progression of kidney disease؟ معنا وقت شوية نفكر. هو يعني الموست لايكلي اكسبلانيشن يعني طبعا انا مش عارفه مش متاكده 100%. هو الاجابه الدي اللي هو all of the above كله صح ما عدا progression of kidney disease. لان احنا قلنا ممكن even patient يوصل لجي اف ار 15 وما يبقاش لسه عنده metabolic acidosis. ولكن البيشنت ده بنديله very high dose وهو عنده bloating of the stomach فغالبا مش بياخد الدواء. الحاجه الثانيه غالبا مش ملتزم بالدايت اللي انا بقول عليها الهاي بروتين واللي انا فروتس اند فيجيتابلز يعني هو بياخد هاي بروتين وما بياخدش فروتس اند فيجيتابلز فغالبا هو ده السبب مش البروجريشن اوف كيدني ديزيز بتاعه. اخر سؤال which of the following dietary consumptions predispose a CKD patient with estimated GFR of 70 milliliter per minute to hypercholeric metabolic acidosis؟ ايه اللي البيشنت اللي هيخليه يدخل في hypercholeric اللي هو non anion gap او normal anion gap metabolic acidosis؟ fruits and vegetables or high salt intake اكتر من 10 grams per day ولا soya protein meat balls ولا hazelnuts ولا red wine؟ ايه الحاجات دي ممكن تعمل normal anion gap metabolic acidosis؟ طيب هو اول حاجه الفروتس اند فيجيتابلز هتعمل اسيدوزس؟ لا هي بتعمل الكالاين. الهيزل نتس والريد واين نفس الكلام برضه حاجه مكسرات دي كله بيعمل الكالاين ايفكت. يبقى الحاجتين اللي ممكن يعملوا اسيديك ايفكت هما الهاي سولت انتيك والسوي بروتين ميت بولز. السوي بروتين ميت بولز دي ميت بروتين هيطلع لي بعد كده فوسفيتس وسلفيتس فيعمل لي هاي اناين جاب يبقى هيتفضل الهاي سولت. الهاي سولت صوديوم كلورايد. صوديوم كلورايد هو ده الميكانيزم يعني دايما حتى في النورمال اناين ميتابوليك نورمال اناين جاب ميتابوليك اسيدوز بتحصل لو انا اديت العيان سلاين انفيوجن كتير صوديوم كلورايد كتير لان البايكارب بيقل والكلورايد بيزيد والنورمال اناين جاب بتريمين نورمال. ثانك يو.